Hi, and welcome back to MedTutes. In today's video, we're going to discuss some cardiac physiology, specifically looking at the pressure volume curve. For this example, we're going to focus predominantly on the left ventricle. However, these concepts can be applied broadly. The reason we're going to use the left ventricle as the example is because it's the one that's most frequently used in diagrams, and because it then gives us some anatomical markers that we can discuss instead of a broad kind of overview. So when we talk about the pressure volume curve, we're really looking at the stages of heart contraction and relaxation. And if you've got pressure on the y-axis, volume on the left axis, we can actually calculate, we put in specific values, so calculate specific volumes, specific pressures. But for the moment, I'm going to leave these blank, and we can put in some variables later on. So the way to think about the curve is the curve kind of functions like this. And what it shows is one complete heart cycle. So it shows one round of systole and one round of diastole. Remember, systole is when the heart is contracting. Diastole is when the heart is relaxing. The way that I think about this is that when people die, their heart relaxes. The heart stops pumping. So diastole is the period in which the heart is relaxing, it's not pumping. Cool. So if we start in this phase here, what we can see is that there's the volume of the ventricle is expanding, but the pressure is remaining the same. So what we can tell straight away is that this is the filling time. So this must be diastole. And what this period in particular is the passive filling time. So this is the period in which the ventricle is filling, and it's like filling up an empty balloon. There's currently no resistance to it filling. We get to a point here where there's a slight bump in the curve. And what this is actually showing here is the atria contracting. So when we get to this point right here, what's happening is the ventricle is now full of blood, and in order to push a little bit more blood in, what an atria does is it contracts, it squeezes that tiny bit more blood into the ventricle, and in doing so, it actually starts to stretch the ventricle out. So now it's not just passively filling the balloon up, you're now actually blowing a bit more air or a bit more fluid into the ventricle, into the balloon, so that it's now starting to expand. And there's now some elasticity required. There's currently now a force that's now pushing back on the fluid. And that's what causes this increase in pressure. So this point here is the atria contracting. And then this point here is your mitral valve closing. So if you were listening with a stethoscope, this is the point at which you'd hear S1. The first lub sound. Because heart sounds are actually related to the valves closing. So at this point here, you've got the atria, it's contracted, it's squeezed a little bit more blood into the ventricle, and now the mitral valve has closed. Why does the mitral valve close? Well, if we draw a real quick schematic of the heart, so left atrium, left ventricle, this is where your mitral valve is, and how it looks is it something like this. If we're just looking at the left part of the heart. So this is the left atrium, this is the left ventricle. And when it squeezes, it's squeezing blood back into here. And you see that these are your mitral valves. And what happens is when the pressure in your left ventricle becomes greater than the pressure in the left atrium, then suddenly there's a force that starts to push back against these valves. And because they're angled like this, they can allow fluid to go back this way, but as soon as there's a pressure that pushes back, what it does is it causes the valves to close up. And then the pressure starts pushing against those, and it stops blood from shooting back the opposite way. So when the left atrial pressure is greater than the left ventricle pressure, it allows blood to pass in freely through the valves. As soon as that swaps, they snap shut, and now blood can't rush back. So mitral valves close, S1 lub sound. What you can see now here is that our volume, this should be a straight line, by the way, it shouldn't be curving back. But this should be a straight line that goes straight up, indicating that our volume is remaining the same, but our pressure is now increasing. This is what we call volumetric contraction. So what's happening here is the walls of the left ventricle are now squeezing shut. They're squeezing. And as they squeeze, they're pushing, because it's in reality, we know that it doesn't actually look like this. It's actually more like, if we look like that, this isn't going to be anatomically correct, but if we have the aorta down the bottom here, then this is another valve similar to the one above. And the pressure up in here, if say in a normal person, this is ranging between 80 and 120 millimeters of mercury. The left atrial pressure is very low, like 3 to 4, if that, usually lower of millimeters of mercury. So what happens is that when your left ventricle pressure is greater than 3, but less than 80, there's this period in which it's going to be contracting and both valves are going to be shut, right? And what we need to do is we need to generate pressures greater than the diastolic pressure in order to then push that valve open and allow blood to exit. And that's what's happening in this period here. In the isovolumetric contraction, it's currently squeezing, trying to build its pressure up to this point here. This point here is your aortic valve opening. And if you take this across, this is equal to your diastolic pressure. Because your diastolic pressure is the lower pressure, so for example 120 on 80. It's the pressure that's left in the aorta just before systole, during diastole, which is equivalent to the period just before systole occurs. So it's the lowest pressure, and therefore it's the one that your left ventricle is squeezing against in order to try and open the aortic valve up. What then happens here is we have ejection. So ejection is the blood leaving the left ventricle now and going into the aorta. And something happens as that occurs. So as it's squeezing all this blood out into the aorta, so say this is the aorta, suddenly there's less and less blood in the tank here. That starts dropping down and down and down. And as it does, the pressure in your left ventricle will start to drop, which is what we start to see from this point onwards. And at the same time, your pressure in the aorta, there's more blood happening in here, which means the pressure is rising in your aorta. So there reaches a point when your left ventricular pressure drops below that of the aortic pressure. And at that point, the blood starts to rush back down. So it starts to rush back down because there's no longer a force pushing it up. It hits the valve, which is sitting here, your aortic valve, and the same thing happens as before. The blood comes down, catches the aortic leaflets, and slams the valve shut. So that's what we see here, aortic valve closing. And again, that's what's going to give us our sound. That gives us S2, the dub sound. So lub-dub. The dub is the aortic valve closing. And then this point here, this gives you your systolic pressure. This is the highest point in the curve. We then have this period here, which is similar to before. This is your isovolumetric relaxation. Where your volume is the same, but your pressure is gradually decreasing. And again, it's the same concept as before. It's because our left ventricular pressure is now below the aortic pressure, but it's still above the atrial pressure. So until it drops below that of the atrial pressure, the mitral valve will stay shut. And then at this point here, the mitral valve opens. So then we have, and then we go back into our passive filling stage. So these relaxation periods, these are your diastolic periods, and then your systolic periods are here and here. Your contractility periods. The final thing to make note of is that this pressure here, this volume, this is the volume that gets passed out in one cycle. So this volume here is your stroke volume. And the reason that it never goes, it's not right over here, right on the zero, is because there's this idea of physiological reserve. So with each stroke volume, there is actually still some volume of blood which remains in the ventricle, and that stays there to assist with increased physiological demand. So when demand increases, you can increase contractility of the heart to expand the stroke volume without necessarily having a greater preload, because you can make use of this physiological reserve volume, which isn't being used yet over here. So that's the pressure volume curve. I hope that makes it a little bit more sense. If you'd like more content, you can check out MedTutes website, medtutes.wordpress.com. Make sure you're subscribed to the channel if you enjoy the content. We've got plenty more videos on the way. We also have a podcast called Drug Bites, which is short little snippets of pharmacology. You can find them wherever you listen. Thanks very much for watching.